I'm Brett Tully. I'm chair of the research committee here at the Woolcock Institute, and I want to welcome you to our very special Friday respiratory research seminar. Before we begin proceedings, though, I would like to acknowledge the traditional owners of the land from where I am hosting this virtual seminar, the Gadigal people of the Eora Nation, and I also pay my respects to their elders past, present and emerging. We're very pleased that Professor Grant Waterer, who delivered the Anne Woolcock lecture for 2021 last Wednesday evening, has kindly agreed to present to us again. And today he'll be presenting on community-acquired pneumonia, more proof Aristotle was a smart man. Hopefully many of you attended Wednesday evening's Anne Woolcock lecture, where Professor Waterer took us on a historic journey through infectious disease over the ages and ending up with some of his current research findings. Especially as a non-clinician researcher, I was interested and I underappreciated the relationship between respiratory infectious disease and heart attack and stroke. So that was an eye-opener for me. Professor Waterer is known to many of us. He's a professor of medicine at the University of Western Australia, adjunct professor of medicine at Northwestern University, Chicago, and Curtin University, Perth, and adjunct professor at Edith Cowan University. How you find time to be a professor at so many places? His main research interests are in pulmonary infections, especially pneumonia and non-tuberculosis mycobacterial disease, as well as bronchiectasis and COPD. And he's the ATS chair of the recently published Community-Acquired Pneumonia Guideline and a member of the 2017 HAP-VAP Guideline Panel. So the presentation, as usual, will be recorded this morning. So please be aware that any contributions you make will be included in the recording. And we'll have time at the end for questions. So please raise your hand using the little function that Zoom's got down the bottom for reactions. You can raise your hand at the end and that will put them in order so that I can go to you and ask you to ask your question. Or if you find that difficult, you can just put in the chat that you want to ask a question and I'll also go to you there. So thank you very much. And thanks, Professor Waterer.
Thank you, and thanks for the kind introduction. And I really do appreciate the honour of being asked to do these lectures. It's a shame I couldn't be there to have all the interpersonal interactions, but hopefully in the not too distant future. I don't have any particular conflicts of interest, no relationship with tobacco, and given it's me, I'll almost certainly stumble into off-label conversations at some point during the presentation. I do want to acknowledge that this lecture series and Professor Anne Woolcock, I only heard her speak a couple of times, but for people like me starting out in the late 90s, Anne was a beacon of the fact that as an Australian, you could be a true international leader in our fields. And that is actually really very important. And so I'd really like to acknowledge her contribution. I'd also acknowledge the traditional owners of the land on which we meet. For me, that's the Whadjuk people of the Noongar Nation, and acknowledge their elders past, present and emerging. Given my talk on Wednesday, a lot of you know one of my other passions is history, and particularly the ancient medieval periods. And Aristotle has a lot of great quotes. It's the mark of an educated mind to be able to entertain a thought without accepting it. And with that in mind, I'm, I guess, indulging myself again, but I'm going to just run through what I think some of the key things of what have we learned about pneumonia in the past 25 years. But given the whole theme of today in research, what have we learned that we don't know about pneumonia that we really need to focus on? A little look at what COVID-19 research has taught us, or at least how some of the data that's come out should make us interpret some of the stuff. But in particular, particularly for some of the younger researchers, why you really need to read beyond the abstract, and how a lot of stuff that's been published has really taken us up a garden path. Just to put things in a little context, and I showed this again the other night, if you go to PubMed and put in COVID-19, as of Wednesday, 191,000 citations. If you put in pneumonia for the 20-year period of 1990 to 2019, only 159,000. If you put in influenza, only 97,000. And that just shows what we can do when we want to, but I think also how under-researched pneumonia and influenza has been. For what is the 6th leading cause of death in Australia, the 2nd leading cause of death worldwide. So these are the recent guidelines that we published, and there's a whole lot of interest in politics in that. But the starting point of all guidelines is radiologically confirmed pneumonia. And you'd think for something that is so common that in actual fact, the diagnosis would be very clear cut. But do we really know what pneumonia is? So I think all the clinicians would agree, this is a slam dunk pneumonia. However, is this pneumonia? Now, if I said this is a pre-screening X-ray for a total hip replacement in a completely well person, everyone would go, the clinicians would probably go, oh yeah, I don't think there's anything happening there, that all looks okay. However, I told you this was someone who had a fever, was coughing up green phlegm and had crackles at the right base, clinicians would be tempted to go, oh, looks like there's a little bit of stuff down there, and potentially code that as pneumonia. Now, in clinical trials, these two patients all get grouped together as the same disease. Clearly, they're not the same disease. And this really was the first paper that came out that really shattered our 100-year paradigm of pneumonia is based on a clinical syndrome and a chest X-ray diagnosis. And this is one of the papers I'm more proud of. It's not my own paper, but as the reviewer, when they first presented this paper, they really presented it as CT scan is useful to clinicians, and they really didn't understand what they had. And I got the editorial for this just because I think I put them through about 6 revisions until the final draft. But what they did was they took 308 patients presenting to the emergency department with clinical features suggestive of pneumonia. They got a chest X-ray, and then the clinicians made a diagnosis of pneumonia or not. 188 of these patients, the clinicians said, yep, pneumonia is present. In 120, they said no. They then went and did CT scans. And in actual fact, when the clinicians said yes, the CT scan said yes in 132, but no in 56. When the clinicians said no, the CT scan said yes in 40 and 80, they said no. So essentially, 30% of patients thought to have community-acquired pneumonia had a negative CT scan. A third of patients with a normal chest X-ray had CT findings consistent with pneumonia. And overall, 40% of patients were misdiagnosed if you consider CT scan to be a gold diagnosis, the gold standard for the diagnosis. And that has to fundamentally change how you consider cohort studies of pneumonia and research in pneumonia. If our gold standard's been what clinicians think is pneumonia, then 40% of the time we're getting it wrong. And this is not just because Belgians are bad clinicians. This has been repeated now in a number of studies, including in MRI studies. Those of you who are familiar with the pneumonia literature will know that the Port study, which Michael Fine did, which is, for me, is the gold standard now for cohort studies, because to my knowledge, they've got 139 papers now out of a 2-year cohort study. And the primary paper, I think, has been cited something like 10,000 times itself. But in this study, when they went back and looked at the radiology, 2 radiologists could only agree in 78% of cases that pneumonia was present. So our fundamental study of pneumonia, radiologists only agreed that pneumonia was present in about 4/5 of people. And the only predictor of radiologists disagreeing was whether there was a history of smoking. We also know that in acute exacerbations of COPD, if you do CT scans, you find a lot of pneumonia. So 70% in this series. And this Canadian series, when they took patients with acute exacerbations of COPD and did CT scans, a third had consolidation. So the clinician had seen the patient, assessed them, looked at the chest X-ray and said, acute exacerbation of COPD. Yet a third had consolidation. And by the way, I apologize for my voice, but I've been off work for 3 weeks with right lower lobe pneumonia from metapneumovirus. So this is personally now interesting, as well as just for my research. In addition to that 1/3, a quarter had ground glass on the CT, And the CRP levels were the same in patients whether they had consolidation or ground glass, but not in patients who had a chest X-ray that was thought to be consolidation versus not. So overall, that means that possibly as many as 50% of our patients with acute exacerbations of COPD have pneumonia. And that becomes really important when we start to look at the cardiovascular and downflow chronic manifestations of pulmonary infection. Now, COVID in itself has driven a rapid uptake in ultrasound. And we're seeing now a lot of studies come out on the utility of ultrasound compared to chest X-ray and CT scan. And ultrasound is also turning out to be more sensitive than chest X-rays. And I think we're going to see now over the next 10 years, a fundamental change in the gold standard of diagnosing pneumonia, particularly because modern CT scans are faster than getting a chest X-ray, and they deliver less radiation than a lateral chest X-ray. So for a disease that is as the most common cause of being admitted to hospital with an infection, the fact that we actually don't have a gold standard that's any good and that we're changing gold standard is both a problem, but also an enormous opportunity. Because as I'm going to present several times along the way, journey here, we actually need to go back and redo almost every fundamental study we've ever done in pneumonia to move forward. Does it matter? Does it really matter if it's pneumonia or not on a chest X-ray, if clinicians are going to treat it that way? Well, that depends on how you look at it. So we published data out of the EPIC study, which was a big CDC study. And out of that, we did have 62 patients in whom the chest X-ray was negative, but the pneumonia was only picked up on CT scan. And what you can see is it doesn't really matter what measure of severity you look at, or what outcome you look at, or whether you picked up bacteria or viruses, there was no difference. So CT-only pneumonia appears to be the same as chest X-ray positive, CT positive pneumonia. So CT positive pneumonia is pneumonia, it's the same disease. However, there are a little bit of data, and this is just stuff that I've been doing with GSK and Jorgen Vespo out of the Salford Study. So the Salford Study was this open label, all-comers study of what happens when you introduce Brio into a community. And my focus was very much, has been on, is a hospitalized exacerbation with COPD the same prognosis as being hospitalized with pneumonia? Because that's a really critical question if you're trying to weigh up what is the risk of pneumonia with inhaled corticosteroids. And if you're trying to decide whether to treat a patient or not, and the patient's concerned about pneumonia, if an acute exacerbation is the same as pneumonia, well, it doesn't really matter because we've got good data that we reduce exacerbations by so much. But if you have pneumonia, if pneumonia was different, well, then you've got to give it a much higher weighting. Now, what it turned out, and this is still going through the journals, if you took the clinician diagnosis of pneumonia versus a clinician diagnosis of acute exacerbation, very clearly over 6 months, you were much worse off, you're much more likely to die if you'd had a clinician diagnosis of pneumonia. But when we put the lens of the radiologist on it and said, well, what are radiologists called pneumonia or not? And 2 radiologists looked at this and there was a methodology. You can see there's actually a very significant difference here. Still pneumonia much worse for you, but the negative signal with an acute exacerbation almost disappears. So getting it right as to whether a patient truly has pneumonia or not may very well prognostically be very, very different. So to switch gears, this pretty much is the conversation we've had with patients for almost ever in terms of when they say, well, what's caused my pneumonia? And, you know, even a year ago, there's no way that I would have known that I had metapneumovirus pneumonia. I just would have had pneumonia and no one would have known what it was caused by. And if you go back to 1998, so 20 years ago, and you look at what causes pneumonia, you would have the textbooks would tell you overwhelmingly bacterial, some viral pneumonia, maybe a few cases where you get multiple pathogens. And your list would have been Streptococcus, Mycoplasma, Legionella, Chlamydia, and then some other viruses, and most studies showing 50 to 70% unknown. Prior to COVID, where COVID is now clearly the most cause of pneumonia in the world at the moment, even prior COVID, we had recognised that viral pneumonia was overwhelmingly the most common cause of community-acquired pneumonia. Multi-pathogen pneumonia, which I'm going to show you some data on, so having more than one pathogen is probably actually even more common than having just one bacteria. And while Streptococcus pneumonia generally tends to be the most common pathogen, all these viruses well and truly recognised now as causing pneumonia. And in particular, metapneumovirus was really only discovered in 2001. And our studies now are still showing around a third to a half of unknown pathogens. So there's still a lot of work to be done in discovering it. But this huge shift from predominantly bacterial to probably predominantly viral is fundamentally very important if you think about the fact that most of our focus of pneumonia has been on what antibiotics do you use. And I think what COVID has shown us glaringly is how poor our development of antivirals has been for common viral infections that kill many, many, many people. So this was the EPIC study, and only my mother can pick up that my name's in the middle of that. The two studies I just want to show very quickly now, the CDC put an awful lot of effort into trying to find what pathogens there were and this was a study that was done in Chicago and Nashville largely. But the most common pathogen, overwhelmingly human rhinovirus, then influenza A or B, and strep pneumoniae. And these lighter colored bars here are all the cases where more than one pathogen was picked up. And the predominant ones where they're picked up, it's usually a bacteria and a virus. Now, in actual fact, the CDC didn't do a great job, and their assay for pneumococcus in particular, their PCR assays were pretty poor. This is a much better study that came out of Norway. They had a much higher pickup rate. They got around 70% of patients having a pathogen. But the key here is blue is only one pathogen identified, and strep pneumo for them was the most common, but again, rhinovirus. And the number of studies, all of our animal studies and stuff, people like Phil, we concentrate on strep pneumo and influenza predominantly. No one does pneumonia studies of rhinovirus, yet CDC and Norway 1 and 3, there's some lessons there. But all these other colors are where you find more than one bug. And so it's more normal than not to find more than one pathogen in patients with pneumonia. So what does that mean? Well, we don't know at the moment whether that means you've got two simultaneous infections, or perhaps you've had a preceding virus infection and now you've got a secondary bacterial infection. And this fundamentally is very different biologically. There's lots of data to show if you simultaneously infect mice or rats or guinea pigs with pneumococcus and influenza, you get much worse disease, much worse destructive lung disease than you do if you do sequential infection. And that kind of makes sense biologically in that our immune response to a bacteria is very different to a virus. And if you ask the immune system to do two things at once, it doesn't do so well. But how we might prevent pneumonia and what treatment strategies we might need in patients may be very, very different. And because we've largely relied on qualitative single point assays, we can't at the moment tease this out. What we need is quantitative multi-time point assays so we can determine if it's truly this or whether it's this. And what COVID has done for us is the whole world has suddenly invested in technology that we've had for 10 years. But now, if you go to an emergency department with pneumonia, you're going to get run through a gene expert or a biofire array, and within a couple of hours, you're going to get back a whole panel of does this patient have. So, metapneumovirus for me was picked up on one of these. And so we're going to have this massive amount of data now coming in because horrible people like me, administrators who've gone, no, too expensive, can't have it. All of a sudden, everyone's got this. We have this huge amount of clinical data coming in now on this patient's got coronavirus XYZ or Coxsackie, or and the bacterial ones at the moment are quantitative. The viral ones are becoming quantitative. We're going to enter this golden age over the next decade where we're going to have to interpret all this masses of data and what it means. And the quantitation is actually absolutely critical as well. So this is some earlier data we did with Jordi Rello and a Spanish group showing that the amount of pneumococci you have in your blood at presentation predicts whether you're going to go into septic shock. And I think we've documented now over 60 cases where people have come in relatively well with high bacterial loads and it's still 100% going to septic shock. We've shown that with other causes of sepsis, and people have also shown that now, for example, with kids with RSV, their prognosis is very much determined by how much RSV is in their respiratory secretions. It's been shown with other things, for example, obviously HIV, hepatitis C and B, CMV. How much you have is also a very critical part of the equation. And we're going to start to get all that data. And that's going to open up enormous opportunities for research, both at a basic science level, but at a clinical level. And if people are looking for, where is my opportunity at the moment, this huge uplift in diagnostics is going to change how we think about pneumonia. Because I think we're going to stop talking about community-acquired pneumonia. And what we're going to talk about is metapneumovirus pneumonia, or pneumococcal pneumonia when I have influenza, or pneumococcal pneumonia when I also have rhinovirus. And community-acquired pneumonia is going to disappear as a concept, and we're going to focus on the actual bugs, as well as how much of the bugs, as well as what other bugs are present. And there may be very different treatments that you need if you have pneumococcus and influenza versus pneumococcus and RSV, for example. And that is going to open up enormous opportunities for research and drug development. So the high-minded man must care more for truth than for what people think. So the community-acquired pneumonia guidelines are very clear that a beta-lactam and a macrolide is the preferred choice for any patient that's admitted. And that is completely and utterly and somewhat embarrassingly for me at odds with what the Australian therapeutic guidelines currently say, which is they prefer benzoyl penicillin and doxycycline, which I think is completely and utterly absurd, for non-severe inpatient pneumonia. And for this reason, I'm frequently invited to infectious disease meetings to be the person that they can throw fruit at. This is the first paper that I published, and still probably the one that is most cited. And this is an example of flexible thinking. So I started this work when I was in Memphis because I was incredibly frustrated by how many times they were adding vancomycin to patients with community-acquired pneumonia for what I thought was absolutely no reason. So I started this research to try and prove that clinicians in Memphis, and this was a 3,000-bed hospital, were using far too many antibiotics. And when the data all started to come out, the signal in the data was overwhelmingly, if you got 2 antibiotics with pneumococcal pneumonia, you had a 6 times better chance of surviving. And further data showed that it was the addition of the macrolide that was making the difference. And this was kind of fundamentally an anathema to the current paradigm of if you've got pneumococcus and it's penicillin sensitive, you give penicillin, end of story. And there are still ID physicians out there clinging to that. Now, Gattarello from Barcelona, from Jordi's group, they looked at 2 big community-acquired pneumonia in the ICU studies between Capucci 1 and Capucci 2 that were done about a decade apart. And what they showed was that in between these 2 time periods, there'd been a 1/3 decrease in mortality in septic shock, a 27% decrease in mortality in those requiring mechanical ventilation. And the two factors were, between these two time periods, they'd added in macrolides, and that was associated, as you can see here, a highly significant odds reduction in mortality, and they'd moved to giving antibiotics a bit faster. And as well as dozens of other studies after mine that showed exactly the same thing, this data shows how powerful adding a macrolide is in reducing mortality. Now, there have been 2 attempts to try and do a proper randomized controlled trial to finally settle this question. The first was by Postma, and this is my first example of where you've got to read the literature really carefully. So this study is continually trawled out by people to say, no, a single antibiotic therapy is perfectly fine. There's a New England Journal publication that says so. This was described as a pragmatic design of a randomized controlled trial. What they mean by pragmatic is that clinicians ignored the randomization 40% of the time. 25% of their patients didn't even have chest x-rays. In the monotherapy arm, which was mostly fluoroquinolones, the 39% of times, so it was fluoroquinolones or ceftriaxone, 39% of the time, the patient had a macrolide added to them. So almost 40% of the monotherapy arm was actually beta-lactam macrolide or moxifloxacin and macrolide. And in the macrolide that was added in the monotherapy arm was overwhelmingly azithromycin or clarithromycin. In the combination therapy arm, more than a third had erythromycin as their macrolide. Equally, in the monotherapy arm, only 2.1% had benzylpenicillin, whereas nearly a third, or 30% anyway, had benzylpenicillin. So this was a trial of amoxicillin plus or benzopen plus erythromycin versus another combination therapy. And so it's really a study that tells us nothing about nothing. After I and a couple of others gave enormous criticism of this paper, they then snuck this one, severe patients were excluded. They then snuck this paper in 2019. They went back and looked at their data and showed that in patients who got erythromycin, there was a 2/3 increase in cardiac events. So this is really a study that shows erythromycin is not great treatment for pneumonia. Garin and colleagues in Switzerland attempted what was actually a really interesting way to try and tackle the problem. So they said, if you are developing a new antibiotic, what you have to do for the FDA or the EMA is prove that your antibiotic isn't worse than other antibiotics that are there. So an standard non-inferiority trial. And they did this in patients, again, not the most severe group of patients, but all common community-acquired pneumonia. And based on their prior, commentaries and editorials, they were very much believed that combination therapy was a waste of time. The end result of this trial was they weren't able to prove that combination therapy they weren't able to prove that monotherapy wasn't inferior to combination therapy. So based on their approach, if you were trying to register monotherapy, you would not be able to register it because it has not met the non-inferiority criteria. So we still don't have a great study to finally answer the question that's come out of all the retrospective studies. REMAP-CAP, and I'm going to talk about platform trials before I finish, is going to try and address this. But there's absolutely no question that beta-lactam macrolide combination therapy is first choice for pneumonia, and I think it's disgraceful. Our current guidelines include the option of benzylpenicillin and doxycycline. This, I think, should be taken to heart for all of us academics. So, having been involved in the guidelines, one of the really interesting things politically is how the meta-analysts and the methodologists have created an industry for themselves. And I must admit, as a section editor for ERJ and someone who reviews a lot of papers, I get very frustrated by the sheer number of meta-analyses I get asked to look at. Steroids for community-acquired pneumonia, there is now something like 16 meta-analyses that all show exactly this, that you should give steroids because there's lower mortality. And this is a classic example for me where bad meta-analysis is really harmful, because based on these meta-analyses, there was a little study done by Kaiser recently that 75% of patients with community-acquired pneumonia in the US were routinely being given corticosteroids. So prednisolone at 50 milligrams a day. If you critically look at this, all the mortality signal here is driven by NAPHA. This is the paper in the eminent Egyptian Society of Chest Diseases and Tuberculosis. And 60 patients on steroids versus 20 on placebo. They say it was stratified by severity, but we've got no information. And the deaths was 6.7 versus 30%. When you go to the paper, no significant difference in anything. However, if you go and do the stats yourself, the patients on placebo had significantly worse renal function than those who didn't. And even the oxygenation becomes close to significant difference. But essentially, you've got 20 patients with abnormal renal function versus 60 patients who have normal renal function. And entire countries and tens of thousands of people have had their treatment changed based on that. If you go to one of the other papers, Sabri and Omar, another paper coming from a similar area in a similar type of journal, 40 versus 40, claiming that there was no difference in outcomes other than somewhat better oxygenation and chest x-rays in the steroid group at day 8. And again, when you go to the paper, the number of patients on mechanical ventilation, 85% in the placebo at enrollment, 65% in hydrocortisone. They say not significant if you go and do the chi-square at 0.04. So again, not particularly a robust study. If you look at Conflorioni here, which is Umbodo Maduri, who I'll talk about in a second, is one of the authors of. This was a study where that started it all off, saying that, look, if you give an infusion of hydrocortisone, there's a massive difference, and they stopped these patients after 46 were enrolled. Now, in this study, there was 0% mortality in those who went to ICU with severe community-acquired pneumonia, 0%. That's never been remotely produced by any other study. And I don't know anyone other than the authors who believe that this is real data. If you take those 3 studies out, no difference. Tony Torres did the best study that's been published to date, looking at prednisolone in a group of patients with severe pneumonia and high CRPs, 61 versus 59. 3 high enrolling sites took 5 years to enroll in this study, which tells you how selective the group is. And they showed less failure of clinical response at 7 days, but it was all due to the chest x-rays looking better at 7 days. So you have to ask yourself, if a chest x-ray looks better, but there's no change in mortality, no change in length of stay, no change in organ failure, does that mean anything? Now, what has not been published, but is sitting there on clinicaltrials.gov because they were forced to, because it was a Veterans Affairs sponsored study, is the largest study we have by a long way of steroids and community-acquired pneumonia, where Umberto Maduri is the senior author, or at least the PI. The trial finished in 2017, and we were aware at the time the guidelines. It was complete and analysed by 2018, and they were forced to publish the results in October 2020. This was severe community-acquired pneumonia defined as meeting ATS criteria, requiring steroids for 7 days and tapering off. And 60-day mortality, which was their primary endpoint, was absolutely no different. You throw this into the meta-analyses, which I've started to insist people do when they present me with these papers for publication, any kind of significance completely disappears. And this is why I think clinicaltrials.gov is so important, because if authors decide not to publish their results when this is the largest study we have by a long way, then we've got a real problem with the literature. And so this is critically important, and why people need to go and look at clinicaltrials.gov when trying to decide how to interpret results. And I will also say, just as a reviewer, looking at clinical trial papers and then going to clinicaltrials.gov, the number of times authors try and change their pre-specified primary outcome to one that they've done post hoc is quite shocking. In interest of time, I really won't go through too much other than to say that the data that steroids reduce length of stay is all due to the fact that people get, in these studies, people have been in hospital for a week or more. And for example, in these two studies, they give people routinely 10 to 12 days. And it's all due to steroids being a bit of an antipyretic. So the meta-analysis, frankly, are lazy publications with lack of adequate scrutiny of the primary data, and steroids in CAP have no meaningful impact. There is evidence of harm. Again, almost all observational studies showing that for viral pneumonia, influenza at least, we'll come to COVID in a second, worse outcomes. And this much better study, the propensity matched severity study from the VA database, again, raising real concerns about using steroids in influenza with much higher mortality. And short courses of steroids are not benign, much higher rates, even at the kind of 5 days we give for COPD. Much higher rates over 30 days of sepsis, pulmonary emboli, and DVT and fracture. But they do work in COVID, and that's because the pathology is different, but also when you go to recovery, and we haven't seen similar analyses from REMAP-CAP yet, but the data was all driven by better outcome in age under 70. Clearly a lesser effect in women, and less than 7 days, no impact. So while we should use steroids in, based on the data, we've got to be cognizant that it isn't every patient that's getting a benefit out of steroids here. This is like many studies where there is a subset that is driving the benefit, and some of these people may actually be being made worse, and how you pick that is important. And what the higher quality centres are noting is there are significant increased rates of ventilator-associated pneumonia and secondary sepsis, and some reports now coming out around the post-care critical myopathy and neuropathy that we know steroids drive. So that we should still give them, but I think the jury's still out on an individual basis on steroids. And there is an issue with the platform trials, and especially recovery. So if you look at the placebo mortality, so REMAP-CAP, you've got to have severe COVID to get in. Recovery was basically hospitalized patients. So recovery should have a much lower mortality than REMAP-CAP. But even at REMAP-CAP, the placebo mortalities are 36%, 35%. If you look at published data, the best institutions are publishing mortality rates between 50 and 20%. And there are massive differences in severity adjusted mortality between institutions in the UK and the US, up to 3-fold. If you look at the Victorian data, it was 15% mortality in ICU in their tranche last year, 11% outside the ICU. I haven't seen the detailed New South Wales data, but as far as I can see from tracking, New South Wales is tracking under 15% for ICU mortality from COVID. So you've got to ask yourself, how valid are these studies when you're seeing 35, 36% mortality in your placebo groups, 28, 31 with treatment, when we're seeing this? And so platform trials may be real life, but because they've encouraged everyone to throw in, you have very different risk-adjusted mortality between high-performing hospitals and low-performing. And that's not just clinician acumen, that's issues of how stressed, how overwhelmed were you at the time? What's your resourcing? So some hospitals, you've got 1 in 3, 3 patients per nurse in ICUs as a norm. What's your equipment? All of that kind of stuff. And I think what we haven't seen from platform trials, and again, this is really critical, is, is it that, so if this was, what's the range of mortality for a mortality adjusted outcome? And if you've got this range in hospitals, is the steroid effect the same whether you're in a high performing or a low performing setting? Does the impact diminish as you get down to the better performing hospitals? I guess in theory, I think it's very, very unlikely. In theory, is the impact even larger in high performing hospitals? But what lots of my colleagues in the high performing settings are worried about is this is the actual case, that in some of the highest mortality hospitals, you're seeing a big benefit. But what they're noticing, for example, in Barcelona, in Northwest, and in Baltimore, is that their mortality has actually gone up a bit since steroids were introduced. And this may be the case. And so, we've got to look at platform trials critically. So meta-analysis has its place, but only if done well. And it's not the gold standard. And just to point that out, this is the ivermectin meta-analyses that have led to almost 1 million people being treated with ivermectin around the world. And it turns out this paper, Alcazar, is completely false. The data was completely made up. So, meta-analyses, they got their problems. Excellence is never an accident. It is always the result of high intention, sincere effort, and intelligent execution. It represents the wise choice of many alternatives. Choice, not chance, determines your destiny. So the last phase of my talk here is, foremost ever, clinicians who treat inpatients with pneumonia, the general attitude can be summed up as, go home now, go and rest, we've done our job. We know that for every death in hospital, there's more than 8 deaths in the subsequent 2 years. Inpatient mortality from community-acquired pneumonia is the tip of the iceberg. Lots of data. This from the Port study, which of course I already talked about its problems with its chest X-ray, but whatever age group, and increasingly with age group, compared to population controls, significantly increased mortality over 5 years. This is some of my earlier data, and this is really important because maybe I'm a rubbish clinician, but these are patients that I all assessed clinically myself. And if you had no comorbidities, so not even hypertension, and you were 40 years of age or 45 years of age, you had a 14% chance of being dead within 2 years. If you were 60 to 80 and you had community-acquired pneumonia and were completely well prior, you had a 1 in 5 chance of being dead in 2 years. And that is something like 8 times and 7 times the average of the community. And this is a Finnish study where they looked at it over 20 years, and this gap gets wider and wider, and it's all driven by cardiovascular disease. And people like Corrales Medina from Canada, this is an analysis of the congestive heart, the cardiovascular heart study, which was a study in 65s to 75-year-olds, a long-term cohort study. The atherosclerosis risk and community study was a study of 50-year-olds to 75-year-olds. And they looked at patients who had pneumonia versus age, sex, and comorbidity smoking matched controls. And what you can see here is if you have pneumonia in the first 30 days, a 4-fold increased risk of heart attack or stroke if you're in the older cohort, almost 2.5 times in the younger cohort. And this risk, this is odds ratio 1 here, is well out in the 90 days to 1 year. Equally, new onset heart failure significantly increased in the 1 to 5 years post pneumonia. Why? We know that acute myocardial infarction is common, and this is grossly under-recognized in community-acquired pneumonia. There are a number of studies. There's a big UK study started on aspirin in community-acquired pneumonia for this. Best demonstrated probably by this Italian study, who went to great depths with ECGs and cardiac troponins, etc. 10% of their cohort having evidence of myocardial infarction. Data like this from Marcos Restrepo's group showing that with pneumococcal pneumonia, you get significant myocardial infiltration with pneumococci, which leads to fibrosis. And he demonstrated this really nicely here, that this is the pneumococci in the myocardium, no significant neutrophilic response, but this is the pathology. Sorry, this doesn't project well, but I'm working with two different cardiologists who interestingly don't like each other very much. One's doing MRIs in acute patients, and we're finding about 40% of patients with bacterial pneumonia have myocardial evidence of acute myocardial focal injury, which almost certainly is what Marcos has been describing. We know that inflammation drives this higher mortality. So this is from the Genome study. Those who had the highest inflammation at discharge had the highest 90-day mortality. And this is a paper that we've been doing some work on PET scans. And even at around 2 to 3 months post pneumonia, you can see here it's still very significant inflammation present in the lung. And it's important to remember that even tiny amounts of inflammation can have really substantial impacts. So just to point out, this is 2 Danish studies of patients with COPD, and they defined an inflammatory profile. They gave you a point if your CRP was above 3, a point if your fibrinogen was above 14, and a point if your white cell count was above 9. And what they showed here was, if you look at myocardial infarction, even 1 point, 2 points, 3 points, and these are not great. These are not high amounts of inflammation. These are tiny amounts of inflammation. So for me, the idea that resolving pneumonia is some kind of healthy biological process is about as rational as continuing to drive on a flat tire. You can do it, but you're doing damage. And I think our whole paradigm, again, if you're looking for a research opportunity, our whole paradigm has to change, that this resolving inflammation is a natural process we don't interfere with, that this resolving inflammation is actually chewing up your arteries and potentially your myocardium. And we've got to do better. We've got to change our thought processes as clinicians, and we've got to treat pneumonia as a chronic disease that has bad outcomes, and we've got to find ways of changing those outcomes. So I'm sorry it was a quick spin and probably far too fast through areas of pneumonia that I find interesting. Imaging is changing our understanding of pneumonia, and that's going to fundamentally both make us redo many studies. That's a huge area of opportunity. The fact that multi-pathogen pneumonia is the norm, got to change how we consider pneumonia and what kind of treatments we might like. Thankfully, all this new technology that we've finally got because of COVID is going to fundamentally change how we think about pneumonia and the data we have, and we're going to have to understand it. Beta-Lactam monotherapy is out. Beta-Lactam and macrolide therapy, except maybe for my mother-in-law, she's welcome to have a Beta-Lactam alone. You know, this is my soapbox, but the data is just so overwhelming. Why you would not treat someone with this is beyond me. For the younger researchers, I don't need to tell the senior people here this, but just because something's published in the New England Journal doesn't mean it's a great paper. And just because the authors say this, that you know, in the abstract, don't believe it, and don't believe every meta-analysis you read, because a lot of it, frankly, the good stuff is good, but a lot of it is lazy research where they just pluck tables out of papers and don't critique the original papers. Platform studies have moved us forward enormously, and it was criminal how some of the early COVID studies in China and Italy, where they were throwing, you know, pulse methylprednisolone and hydroxychloroquine and ritonavir and beta interferon and almost everything you can imagine at patients with no consent. It's not a surprise that we're talking 50% mortality rates. And if you look at some of the early Chinese and Italian studies, up to 20% having recurrent ventricular tachycardia, all these cardiotoxic drugs. So thank heavens for platform studies. They've moved us forward enormously, but they have problems and they're not the final answer. And I think we've got to be cognizant of that as scientists, and never, as Aristotle tells us, always keep our mind open and never accept until we've got absolute proof. The long-term consequences of community-acquired pneumonia are much worse than the short-time ones, and we have to change our focus. And every new bit of information we get leads to more questions than answers. So the scope is wide for interested researchers. And this really is the quote that underlines my title of my talk. The more you know, the more you know you don't know. And another way of phrasing that is only the truly enlightened know that they're ignorant. Thank you.
Thank you very much, Grant. That was a very interesting talk, and certainly, yeah, I think everyone enjoyed it. You've encouraged us to fill in those gaps in the literature that you identified early on with pneumonia type research and infectious disease research. So thank you very much. We do have about 7 or 8 minutes, so I'm happy to take questions. If you want to raise your hand, and Phil's got his hand up, yeah, that will put you to the top of the queue, and then I can go through it in order. But please, and can I just suggest that people give your name and where you're from? We're a big group now. I think we're at 65, which is wonderful. And other people will know where everyone's from. So thanks very much, Phil.
Okay, thanks, Brett. And thanks very much, Grant. That was fantastic, as always. So really interesting. So I'm Phil Hansbrough. I'm from UTS and Centenary Institute. I'm really interested in bacteria and microbiomes as well. So I'd be really interested to get your thoughts on the role of the lung or respiratory microbiome in lots of things that you've been talking about. So you can imagine pneumonia and antibiotics and steroids are really sledgehammer kind of things. So how important do you think the microbiome is in some of these things?
Yeah, I mean, I think that's really good questions. And of course, the answer is currently we don't know, but we've got hypotheses. Okay. So I think the potential that antibiotics disturb the microbiome and you get a unhelpful microbiome, and we know certainly from the gut that that's true for a number of things. So I think we do need to understand, what does a healthy microbiome look like? And when do patients not get back to that? I think it's probably much more critical in patients who have underlying lung disease. So I think we're starting to really understand in COPD the disturbance of the microbiome, particularly that loss of variability, and that you can see changes in the microbiome that predict that you're going to become a frequent exacerbator. And equally in bronchiectasis. And I think that there's no question that one of the mechanisms by which viruses predispose to bacterial infection is disruption of that microbiome, that healthy microbiome, and opening up that window of opportunity. I think one of the really interesting things, and I didn't cover this, so thanks for the question, is in that 30 to 50% of cases of pneumonia where we don't know what's causing it, evidence is coming out that a lot of things that people have discarded from sputum cultures because they said that's just normal flora, is probably actually causing the pneumonia. Yeah. And so again, that's got to change your perception of how should we treat, what are the long-term implications, and so how we're going to get better data on that is challenging. Because we often only get really high quality data in the severest group of patients that we can get bronchoscopies off of because they're ventilated. But I think that whole interaction of what is normal, what's causing the pneumonia, and then do you reestablish normality? How quickly, and how quickly you reestablish normality, another signal, is really important and one of the areas we've got to explore.
Thanks very much.
Thank you. We might go to Guy. You've got a question? And you're on mute.
Yep, I'm here.
Hi, Guy.
Thank you very much, Grant. It was an amazing talk and really covered so much stuff. And there's so many things I would like to ask you about. And, I particularly was interested in your and support, your comments around the limitations of many published clinical trials, and particularly the so-called pragmatic trial design. And also, the limitations of meta-analysis. I think that was really spot on. There's one thing I just wanted to take you up on and ask you to expand a bit about is the concept of the multi-pathogen pneumonia. For my sort of concept around this is often, you didn't talk about sort of patient risk factors and the extent to which there are sort of commensal, I guess this comes a bit back to the microbiome story that Phil was just talking about, but that there are commensal pathogens, and that what happens when people develop pneumonia, at least in some cases, is not that they're exposed for the first time to an organism, but that an organism which is resident in their upper respiratory tract or somewhere else becomes pathogenic for a reason, for some other reason in that person. And obviously that's not the case with COVID. It's not the case with TB. Well, actually, it could be the case with TB because that it may have been latent in them, but it's not the case with COVID, and probably not the case with influenza, but it may be the case with some other pathogens. And I wondered what your thoughts are about that as an explanation for the multi-pathogen pneumonia that we often see.
Yeah, really good question. So I think it probably depends on the pathogens. So we know, for example, that a small number of people only carry, adults, unlike children, carry pneumococcus routinely. You don't tend to see influenza in healthy people, but you will find, for example, intermittent shedding of RSV and adenovirus in healthy people. And I think you're probably spot on that some of these cases of multi-pathogen pneumonia may be pathogens that have always been there. However, I think the data that viruses predisposed to secondary bacterial pneumonia is incredibly solid and strong. And I think, as I said, the only way I think we're going to sort this out is by having serial quantitative studies, because I think if we had data to show you that there was a very high amount of the pathogen to start with, and then it diminished over time, you would be much more comfortable it was an acute infection. Whereas if the amount just stayed static and was still there a month after the patient recovered, you'd say, well, that clearly wasn't a player. So I think this whole concept of multi-pathogen pneumonia, I'm 100% convinced it's real. The extent of that, which I think is what you're challenging, we will only know by better studies.
Okay, thanks.
Thank you so much, Elena.
Thank you so much, Grant, for this morning's talk and for Wednesday night's talk too. Fascinating. Intrigued about the steroid data in COVID. I'd like to take your view on how much this may be refractory to corticosteroid mechanism, or is it just really overwhelming the system with steroids?
So I think the thing that's been lost a little with COVID, if you go to the autopsy studies, and there are 3 really good ones now that show that in general, people who die of respiratory failure of COVID, there's 2 very different pathologies. The first is an acute viral pneumonitis where there is buckets of SARS-CoV-2 in the lung. And clearly, and these people tend to die early. And clearly steroids is not going to be helpful in that setting. The second group of people die with diffuse alveolar damage and there's no virus in the lung. The virus has been cleared. And that seems to be a dysfunctional interplay between T cells and macrophages. There's a couple of Nature publications on that now. So I suspect that there's a little window of opportunity there to somehow interfere in some crucial lymphocyte-driven pathology there in COVID that we still need to tease out. The overwhelming inflammatory response in the lungs is much more of a neutrophilic one, which of course we wouldn't expect to be responsive to steroids. But I think the data, however, recovery, REMAP, CAP, the Brazilian study in particular, are all very consistent with a small benefit. I guess the point I was trying to make is that I don't think that every patient's going to benefit. And there will be, particularly because it's in the midline for a lot of patients, there are patients we're harming. And as clinicians and researchers, what we need to do is develop ways of telling, in this patient, is the net effect positive or negative? And that applies to almost everything we have in medicine, that we lump everybody together. And I think our job as researchers is to refine. And very clearly, I think probably part of what you were getting to as well is steroids are probably not the best agent for whatever they're targeting. We can almost certainly, if we can identify the mechanism better, we can probably identify better drugs with a better side effect profile and better efficacy.
Sure. Thank you very much.
Thank you. And last question from Helen, and then we'll take a break.
Thanks, Grant. That was another really insightful and thought-provoking presentation. Thank you.
Thanks,
I just want to make a quick comment about meta-analyses, because this is an increasingly huge problem, just the number of meta-analyses coming out. You know, it's not just one on a particular topic, but multiple. The meta-analyses that most stringently follow the grade methodology, unfortunately, the role of the clinical insight is very limited. So you will see that these are being done by people who are methodological experts, but the individual studies may make nonsense when you look at it. So it's really important to see the content of the of the contributors to it, to see whether there's at least some clinical insight. But you actually have to look at the individual studies. I mean, the classic example most recently, for example, was in the update of the US asthma guidelines, where they looked at the effects of intermittent inhaled corticosteroids and included studies that had that term in them. But in the one meta-analysis, they've combined studies where a dose of inhaled corticosteroid was taken whenever short-acting beta-agonist was taken and not any other time, and studies where high-dose inhaled corticosteroids was given every day for 2 weeks or 1 week. So those are shoehorned into a single meta-analysis. And it is actually an ongoing problem because the importance of that methodological rigor is being emphasized. So we do need to stand up for clinical input into meta-analyses, and as you've said, to look at the details of the individual studies. Thanks.
I could not agree with you more. So the community-acquired pneumonia guidelines, ATS took a view that only methodologists should write it and clinicians should no longer be involved.
Yep.
And thankfully for us, I think clinicians still have enormous value. And I absolutely 100% agree with you. We have to fight to continue to have clinicians be key parts of looking at the data, because methodologists don't have the content expert.
Thanks.
Thanks. Thanks so much, Grant. And can we all please show our appreciation for Grant for his presentation this morning? That was very, very good.